It's Dr. Juan Dominguez, so he's here in person, which is great. So Dr. Dominguez, he's a research fellow working at our neuroplasticity and multimodal imaging lab in our School of Psychology at Deakin University, and he really specializes in a whole range of fields, including neuroscience, biological psychology, but he even has a background in anthropology as well. He has a strong research background with numerous publications focusing on brain imaging in a range of clinical populations as well, including work in brain injury patients. But he also has published several papers on the cultural aspects of neuroscience. But today he will give an overview of our ultra-low field MRI study that we have recently started in patients with acquired brain injury. The floor is yours, Juan.
Thank you very much, Karen, for organizing, and Meng as well. Very interesting session. It's really amazing and very, very encouraging to see the progress that's been made on this field that I think has great potential in broadening the reach and scope of imaging and its usefulness. Thank you very much to those of you who are here today. I'm going to be talking to you about an ongoing project and in which we are on the earlier stages for improving portable ultra-low field magnetic resonance imaging in patients with acquired brain injury using artificial intelligence. So we know that acquired brain injury, which include any post-birth brain damage, including things like neurodegenerative disease, cancer, stroke, substance abuse. It's a large public health problem. For example, in 2014, there were reported 2.87 million cases of traumatic brain injuries in the US alone. In Europe, an estimated 394 acquired brain injuries diagnosed for 100,000 of population. In Australia, at least 1 in 45 Australians with an acquired brain injury exhibit also physical and cognitive deficits that influence deeply their independence and their life. Our group, as Karen this morning referred to, conducted a survey regarding utilization of imaging in the clinical setting. And even though there is broad use of MRI, we were interested in why in some cases, or in the cases that is not used, why it's not. And among the answers that we got was, patients finding difficult to tolerating it, and also scanner availability. But also we found that 44% of the respondents, which were health practitioners, indicated that they would prefer if MRI was actually more often used in this cohort. We also have a review of ultra-low field in acquired brain injury, under review. And we found only 21 studies so far, most of them focusing on stroke. Now, 9 of them. We also had 1 study on TBI, 3 on brain tumors, 3 on multiple sclerosis, and 8 others in some other conditions. So, still early times for the application of ultra-low field in acquired brain injury. We found that they were primarily used in the emergency department and clinical care context. They relied primarily on visual qualitative assessment. Importantly, that they found that they can be safely administered in a wide range of acquired brain injury patient situations that couldn't otherwise occur in the context of high field. So, for example, there's one case where a patient with a ferromagnetic intracranial bolt was able to be imaged. Patients with an intra-aortic balloon pump, also with implants and electrodes, or patients under sedation that are critically ill and are very difficult to transport. We also found that ultra-low field was comparable to CT in general, with lower sensitivity, for example, to intracerebral hemorrhage, but higher sensitivity to ischemic stroke. The sensitivity did fluctuate across sequences, with T2 in the best, and followed by FLAIR, and diffusion, the poorest so far, but as we saw this morning, there is important progress being done in this regard. The specificity was concordant with CT and high field across ABI subtypes. Also, we found that only 3 studies have used deep learning algorithms to generate synthetic images that would be equivalent in quality to the high field, and 2 of them reported improvements in image quality, including increased sensitivity or measurements in terms of volumes equivalent to high field, and only 4 studies employed more advanced quantitative methods to evaluate the performance of low field MRI. So there is quite a scope for broadening the application of deep learning algorithms, particularly in this cohort, and applying quantitative assessment methods of the technology. So in this study that we are conducting, the study question is, broadly, is ultra-low field MRI sensitive to detect brain injuries in acquired brain injury patients? Our first aim is to compare manual lesion detection between ultra-low field and synthetic high field and native high field images, and quantitatively compare automated delineation of brain regions between the ultra-low field, synthetic high field, and native high field images. So our methods, well, this is a cross-sectional study with in-group design comparing the ultra-low field. We'll be using the hyperfine SWOOP at 64 millitesla, the synthetic 3D images, and the native 3D images obtained from a Siemens biograph. We'll also be doing some cognitive assessment from the NIH toolbox. Also, we're very interested in participants' experience while being scanned in both systems. So, particularly looking back at one of the issues, one of the reasons that practitioners reported sometimes in not conducting MRI because of the tolerability for patients. We'll be recruiting 50 chronic ABI patients that have sustained a brain injury with positive findings on clinical scans, at least 6 months after the injury and up to 5 years post-injury, and that they sustained this injury in well-being adults. Also excluding people with severe psychiatric disorders and ongoing illicit substance use, and obviously, any MRI safety, particularly for the high field scan. And also, our colleagues at Monash have already acquired 200 healthy controls for training the model. These are some details of the sequences, and we'll be acquiring T1, FLAIR, T2, and apparent diffusion in both systems. And right now our sequences are up 20 minutes for the high field and 30 minutes for the hyperfine. And well, obviously what we're going to do is we're going to use an artificial intelligence algorithm to generate a synthetic image from the 64 millitesla that is equivalent to the 3 Tesla. We're going to use the SynPOC, or synthetic point-of-care algorithm, developed by our Monash colleagues, which is, broadly speaking, an adversarial diffusion-based generative framework that is aimed to enhance the quality of ultra-low field point-of-care, and is trained on pair point-of-care and high-field MRI data to improve the resolution, contrast, and anatomical detail. Which is to say, the miracle occurs here. Our colleagues, Tohid, will be explaining a bit more some of the details of the models in his talk. In terms of our evaluation, we'll be doing qualitative evaluations by neuroradiologists, comparing the ultra-low field and the high field, with a protocol where the low field images are being reviewed before the high field images, and we'll be reviewing for different structural sequences to assess tissue characteristics and identify distinct signal intensities, and also then examination of the lesion locations within a specific brain regions, consider the size, shape, and margins. We'll also be implementing some qualitative methods of evaluating the performance of the image to image translation model. In this case, following a similar protocol that our Monash colleagues have followed in their previous work. For example, here using different images between the source and the target 3D image. In this case, in our colleagues' work, showing a reduced difference between the synthetic image and the target 3D. Also using advanced image metrics like normalized square error, big signal to noise ratio, perception-based image quality evaluator, which also showed superior for the previous model. Also, we'll be using ROI delineation using SynthSec Plus, and also we'll be doing manual delineation of the lesions, and we'll be comparing the volumes across the different low field, synthetic, and high field. So right now, we are still in the early stages. We have acquired 4 patients. Here are some of the demographics. So we have 2 males and 2 females that are older than 50 years. And we have tumors and stroke with time since injury between 2 and 8 years. This is some details of the neuroradiologist assessment. So we have some encephalomalacia, and gliosis, and interestingly, we can see that the ultra-low field were reported consistently to be slightly bigger than the high field. In general, the neuroradiologist commented that the ultra-low field demonstrated well the following: gliosis, encephalomalacia, if big, meningioma. There was an incidental observation of meningioma as well. And there was a significant difference between the ultra-low field and the high field in dural sinuses. In the T2 and flare, the T1 fluid signal was higher on the ultra-low field, and the margins less well-defined on the ultra-low field, which may lead to overestimation of encephalomalacia. And I'll give you a few examples. So this is the example of one patient with tumor, with the resection. So you can see here, obviously, that the quality of the image improves markedly on the synthetic, comparable to the high field, with better contrast and signal to noise. And you can see here that in the ultra-low field, you have it's more blurry. The boundaries of the lesion are less well defined. That is a bit solved in the high field, but at the same time, at this stage, we still, only with 5 patients to train the model, we, have perhaps the lesions a bit dimmer and perhaps slightly smaller. And here you have an example of glioma, which is visible across the 3 images again, more diffuse and blurry in the ultra-low, better defined in the synthetic, but yet again a bit dimmer and potentially smaller. Here another example of a tumor resection with the encephalomalacia, again a bit more blurry, here better defined but potentially dimmer and smaller. It's the same case in here. The only thing to point out extra is that the presence of meningioma, which actually was not yet recovered in the synthetic MRI, but we expect that to be that the model will improve and learn to acquire it. An important thing to point out as well, this project, is that it is a sort of general project in terms of lesions. Rather than focusing on a specific type of lesions, we are sort of aiming at a model that can potentially handle different types of lesions. Also, the model is multi-contrast, so that it will use different modalities to generate the different modalities as well. In terms of our questionnaire, first thing to point out, people were more comfortable than not, but not as comfortable as in the 3T in the low field. There were no concerns about the portable MRI, but they were divided into in terms of whether they wanted to receive the field again as a standard care. They were okay in terms of how they perceive the scanner in terms of the size, the shape, the noise of the scanner as well. But they were again divided a little bit in terms of the comfort in it and the length. But this is also because we believe right now, being just an early stage, we haven't counterbalanced the order, and so they have been scanned 3T and then low field, and so they might be, and they will be a bit tired, during the session for the low field, which happens right after the high field. So, preliminary conclusions, interim. So there's apparent improved resolution and SNR in the synthetic high field. The lesions appear better defined in the synthetic high field, inclusions in size, but dimmer and potentially smaller so far. The contrast is better in the synthetic high field, but it still matches the contrasting controls. And the presence of a lesion may require adjustment to contrast to better match the lesion brains, but obviously that will improve when we have all of the sample of ABI patients. Patients were reasonably comfortable in the portable MRI and had no prior concerns with it, but they were more comfortable on the high field scanner, keeping in mind that they were scanned first on the high field and had more confidence on it as a standard of care. I also wanted to finish, again, returning to our survivor of traumatic brain injury, with a short testimonial that I think drives home two important issues. One, the way in which that people are receiving care for different types of injuries, compared to the type of care that sometimes they get for brain injuries, and also what it means for patients to be in the loop in terms of being having access to scanners that tells them or helps them integrate their injury into their life narrative, and can potentially play a therapeutic role in that narrative as well. So without further ado.
I felt I had a broken wrist not that long beforehand, maybe less than a year beforehand, and I felt I had better care with that than I did with the concussion. Yeah, because I had aftercare, I had physio, I had checkups. Everyone could see I had a broken wrist. They were great, but I had nothing with the concussion because it's a hidden injury, and it's a scary injury. The arm was fine. I could still type. I could still, but the brain, I didn't know if I was going to get back to normal. I knew something was wrong, and it was terrifying.
Yeah, it's sort of, I suppose, very disorienting.
Yes.
And that disorientation also sort of, that is something very important, is your brain. And then, not understanding.
It's my whole being. If I lost that, I couldn't drive. I'd forget mid-sentence. I was crying. That's my whole being. I lost that, and I didn't know if I was coming. And if I lose my mind, I lose everything.
So yeah, so I think that really drives home the message that improved access to images, and where low field imaging can play a role, it might be potentially very important as well for patients. So thank you very much. And obviously, sorry, feel free with that. Thank you, my patient volunteers, and our team members, including St. Vincent's Hospital, Peter Brocci, Jean Lee, and Hamid Aklagi from Monash University, Professor Chen, Tawhid Islam, who will be presenting next to me, and Paris Zavaki, and from our Neuroplasticity and Multimodal Imaging Lab, Professor Kainbergs. Thank you. Sorry.
Thanks again, Juan. Any questions for Juan? Feel free to raise any concerns or questions.
Can I ask that?
Yeah, of course, man, go for it.
Thank you, Juan. That was very nice. So when we acquire these brain injury patients, what kinds of lesions do you think you will hope to see, at 3T that we maybe won't be able to see on the swoop that we want to detect?
Well, I suppose it has to do with the size and perhaps with microbleeds. I think as you were pointing out. Oh, sorry. I think as you were pointing out, eventually, the deep learning might be able to, reveal these images. I'm not sure that this, how far we are in that regard, but I think that we want to make sure that that we can be much more certain on what we can see. I think that before we sort of focus on what we cannot yet see, we want to sort of make sure that what we can see is more accurate. So, like for example, as you saw, the lesion in those images appears bigger, and in terms of precision, we need to sort of have a better understanding of the actual size of the lesion. I think that that's clinically very, very, very important. I will, perhaps let Professor Chen perhaps address, the kind of lesions that we might not be able to see on both of them. But I think, to start with, I think we want to sort of make sure that we have a, much more accurate measurements of the lesions that we could see in the low field.
I guess it depends on, maybe this is a question for you, Karen. These patients are mild TBI, or, in the moderate to severe TBI, obviously we'll see hemorrhages, we'll see diffuse axonal injury on the diffusion and so on. But in mild TBI, often we don't see anything. Yeah? The MRI scan's normal, and even the CT scan's normal. So these patients that you're collecting are across the range, or?
Yeah, so these are really a wide range because we really want to explore how good is low field MRI to identify different sizes of lesions and different types of lesions. But yeah, I do expect, for example, in the next few weeks, we're going to recruit more TBI patients, so I expect some issues with the diffuse axonal injuries. But again, with the further developments with the diffusion MRI, I hope to see some improvements with the identification of those injuries as well. Yeah. Sorry, I saw another question as well. Yeah, please feel free.
About the model, apologies if I missed it, but what was the pre-training scheme? Because I assume you would have to conduct some kind of like extensive pre-training with a lot of subjects. So the question is, how many? And were all of them patients, or were there also healthy subjects? Was it just healthy subjects? And what was the lost objective?
Jolene, can I pass that question on to you?
So it's healthy subjects pre-training.
Yes.
So the images are not fine-tuned for the pathology yet.
So it's zero shot. The pictures that the reconstruction that I saw, was it zero shot transfer?
I wouldn't call it zero shot by if it's on machine learning,
Yeah.
zero shot, but it's not fine-tuned.
Okay.
It's not retrained or fine-tuned.
Mm-hmm.
So it's early stage.
Okay.
That's the current limitation.
And how many subjects did you have for the pre-training?
Retraining as one mentioned,
200.
200, but I think the model used 200 to train everything because some of that is for validation as well.
Mm-hmm.
I don't have the exact numbers, but reach out to Toby, he'll be able to tell the exact number, how many for training and validation, pre-clinical.
Mm-hmm. Okay. And the loss is basically like the usual L2 loss, just the distance between the reconstructed, synthesized, and the true 3T images, right?
The loss function.
Yes.
So the latest model we have, the adversarial diffusion model,
Yes.
so you do have a adversarial
Mm-hmm.
loss,
Yeah.
as well as the L2
Oh, right.
L1 loss.
Okay. Okay, cool. Thanks.
Can you talk to us about maybe training a model for other sequence contrasts like diffusion and SWI for brain injury?
Yeah, so that's something we're working on. Right? So, it's multi-sequence training for
synthetic SWI. Sorry, I wasn't supposed to talk about that.
So that's most challenging one. So a lot of individual variabilities for SWI because require some critical thinking. So that's something we can't.
And just briefly as well, just to go back to your question as well of things that we might not be able to see but quantify, particularly in the milder cases, could be also, for example, volume measurements that differ because of atrophy. And so that's not very apparent to the naked eye, but it's something that you can sort of then perhaps more accurately measure in the synthetic rather than the sort of roll of field as well. Anything else?
Comments? No? Thanks. Let's thank again Juan for this wonderful talk.